Good morning. Welcome to another interesting session of Quest. May I ask our chaplain, Father Thomas Ogi Sachan, to lead us in prayer.
Shall we all stand for the prayer? In the name of the Father, Son, and the Holy Spirit. Amen. Loving Heavenly Father, we thank you so much for this day, especially this Thursday, the second Thursday of June 2026. This is the day the Lord has made, so Lord, we rejoice with you. What all we are going to hear today, what all, especially the new things, we'll be able to accept it, we'll be able to understand it, we'll be able to put it into practice for us, for the hospital, for the coming generation. It will be beneficial for each one of us. We pray for Dr. Kamini, Walia. Your presence may be with her, so that whatever she speaks, that will be from you and your ideas that will be implemented to our generation. Thank you for once again for getting us a chance every Thursday that we can learn something new every week. We give you all glory, honor, and praise. In Jesus' mighty name we pray. Amen. Please be seated.
Very good morning to all of you. Yeah, it's my pleasure to introduce Dr. Kamini Walia, Scientist G at ICMR New Delhi. Dr. Walia is a distinguished public health microbiologist with over 20 years of experience in infectious diseases, antimicrobial resistance, diagnostics, and public health research. She holds a PhD from PGI Chandigarh and a Master of Public Health from Johns Hopkins University, US. She has been a key architect of India's antimicrobial resistance initiatives, including establishing the country's first national AMR surveillance network and leading the development of several national guidelines on antimicrobial stewardship, infection control, and diagnostics. Dr. Walia serves on several international expert committees, including those of WHO, GARDP, the Lancet Commission on Diagnostics. She has led numerous national and international research collaborations and has published extensively in leading scientific journals. Her outstanding contributions have been recognized with prestigious awards, including the ICMR Meritorious Performance Award and the INSA Young Scientist Award. And it's our proud privilege that we could be associated with MAM and ICMR in our ongoing ICMR project. And here in BCMCH, we have a very strong culture of research with our CRL lab, our therapeutic drug monitoring cell. So there are a whole lot of people who have ongoing ICMR projects. At the same time, we are looking forward to have more projects. So please join me in warmly welcoming Dr. Kamini Walia over to the stage. And she would be discussing with us about the current landscape of antimicrobial resistance in our country. Over to you, ma'am.
So, good morning, everyone. I'm indeed delighted to be here, and thanks for a very warm welcome. I gratefully acknowledge the support provided by the team here, who are part of the antimicrobial surveillance network in our, which is being funded from ICMR. I will be talking more about it during my talk. Antimicrobial resistance, as you all know, it is a very, very grave public health challenge which is staring on our faces. But it is very less talked about. Mostly people refer to it as a silent pandemic. Now, the reason we say it is a silent pandemic is because it doesn't really attract that kind of attention that viral diseases do. For example, recently there was a lot of discussion on hantavirus or the Ebola outbreaks that happened. It is not a respiratory virus. It is not likely to reach India sometime soon. But then the kind of attention it evokes is much different. Similarly, if we have to draw an analogy, we can talk about typhoid, which claims many more lives in our country. Recently, there was a disease burden estimate published, and it claims much more lives and leads to a lot of morbidity as well as the cost of treatment, but it doesn't get discussed much in our country. So that is the sad part. I have been working in this space for more than 10 years, almost 14, 15 years now. At least now there is a government's attention towards this problem, and we will be talking more about it in my talk. Yet I think we need more participation, we need more sensitization and more advocacy around antimicrobial resistance, because as per one of the estimates, one of the first estimates came out in 2021, which were from 2019. What we saw was there were estimated 4.7 million deaths which were associated with AMR, and more than 1.14 million deaths which were directly attributable to AMR. Now, this is a huge number. If you put together all the HIV, TB deaths, it is much more than that, yet it doesn't even draw that kind of attention. What we see is that the antimicrobial use has consistently gone up. Especially in the developing countries, India, China, Pakistan, Bangladesh, we are consuming much more antibiotics, and in a low impact scenario, it is also going to hit a lot of the GDP that is in discussion a lot these days, post-war mostly. Now, what are the reasons that we have so much antimicrobial resistance in our country? Consistently, we have invested suboptimally in our healthcare systems. That is one of the major issues. Kerala is a very different state. I remember your state launched antimicrobial stewardship policy in 2016. And 8 years after that, your state also brought out a ban on over-the-counter sale of antibiotics. We still will be learning more what kind of impact it had overall, because we don't see the immediate impact on the drug resistance pattern. So it will take few years to understand. Yet, I think it was a very bold step on part of the Kerala state. The challenge is that the antibiotics are mostly overprescribed in situations wherever we do not have a good lab support. In many places, there is no good infection control, and also there are no skilled human resources. It is well understood now that no doctor wants to lose a patient. So wherever the doctor doesn't know what is the diagnosis, wherever the doctor doesn't trust the infection control, for example, in ICUs, he is going to overprescribe to compensate for poor infection control or being blinded on the diagnostics. Then we are a growing economy, and it is well known globally that as people have more money in their pockets, they also buy more antibiotics. And our over-the-counter sale of antibiotics, availability of unregulated sales, rising incomes, they are all contributing to it. And I think one of the most important factor here is the perception of threat. Whether it is the prescribing clinician or whether it is the whether it is the community who's consuming it, they don't realize that, overuse today, how it is going to impact the drug resistance levels in the future. I also sometimes think it is similar to climate change. The carbon footprint we have today, how it is going to impact our generations, we do not know. Similarly, overuse of antimicrobials today, how it is going to impact the drug resistance to those particular antimicrobials in future, we are not able to fathom that. And at the receiving end is the patient, because the patient pays for the higher medical costs for treatment, because most of the time the drugs which are used to treat drug-resistant infections are more expensive. Prolonged hospital stays, increased mortality, and the most important collateral damage, I think, here is the resistance selection. The more higher generations antimicrobials you use, the more selection of the resistant mutants is going to happen. So from one of the studies that we carried out from ICMR, we looked at the incremental cost of treating drug-resistant infections, and what we found was that there was higher mortality in these patients and almost 40% higher cost of treating drug-resistant infection, for example, from E. coli as compared to the drug-sensitive one from the same pathogen. So we are home to almost 18% of the population, and many of the problems that we face in India, they are not seen by the Western countries. The drugs that we need to treat our patients are not the same that we need, that the Western countries need. That is why we really need national efforts, because most of the pharma companies who drive the R&D, for example, for development of a new antimicrobial are not interested in antimicrobials anymore. So one of the companies in India, they have recently released two new antibiotics. One is nephithromycin, which is for the community-acquired pneumonias. I will be talking more about it. And the other is for serious bacterial infections. So that is an Indian company that got an FDA approval. So this is the kind of impact, or this is the kind of initiatives that we want to see more and more coming up in the near future. And our healthcare system also has specific needs. So we also need diagnostics, which are for our country. And because the products developed in the higher income countries may not really fit very well in our healthcare system. So government launched the National Action Plan in 2017 and for 4 years, and now there's another one for 5 years, which was launched recently. And this time, there is a whole of a government approach to it, which was developed by engaging all the stakeholders. There is a framework proposed for sectoral strengthening, and there is a well-defined mechanism for sectoral and intersectoral monitoring of the progress. So most of the Indian research initiatives here I'm talking about till now is focused on generating the reliable evidence, because when we started focusing on antimicrobial resistant in 2011, after the outbreak of NDM, New Delhi metallo-beta-lactamase, this was reported by one of the journals by a group in UK that India is a hotbed for NDM infections. It was found all across the world, but it was easy to target India because we did not have our own data to say that what is the trend in our country. So at that time, government put together the national antibiotic policy, national AMR policy, which I think was a step in there was an acknowledgement at least of the problem, and that was a step in the right direction. Since then, most of the research has been focused on generating reliable evidence, supporting diagnostic, antibiotic, and infection control stewardship, understanding mechanisms of resistance, and also what is the importance of One Health in this entire big AMR problem, which is really the buzzword these days. And we also support a lot of basic and clinical research from Indian Council of Medical Research, and we do this with all these partners. So on evidence generation, there was recently a report by NCDC in which they looked at the prescribing patterns in 35 hospitals across the country. They were mostly government hospitals. They looked at annual consumption, the AWARE classification, what is the access watch and the reserve group, what are the top antibiotics being used, what are the consumption of antibiotics against WHO priority pathogens, etc. And what they found was that they classified access, watch, and reserve as green, yellow, and red. So WHO says that we should be consuming most of the green class of antibiotics, which is the access group, which is the narrow spectrum antibiotic. But what instead we found was that we use a lot of watch group of antibiotics. They are mainly meant for, they are broad spectrum antibiotics, and they are meant for resistant infections. But we use them in the first line of the treatment. As a result, there is a selection of multi-drug resistant pathogens in our country. We are used a lot of ceftriaxone, azithromycin, ciprofloxacin. These are most commonly used. And we are also seeing now last resort antibiotics, about 5%, colistin, linezolid, and estronam. So when we see this kind of a spectrum, it is not difficult to imagine what kind of spectrum we will see in the lab. We will see mostly multi-drug resistant pathogens because your broad spectrum antibiotics are giving that antimicrobial pressure to all the pathogens in the clinics. So ICMR's AMR surveillance network, we focus on 6 pathogenic groups: enterobacterials, gram-negative non-fermenters, enteric fever pathogens, and diarrheal pathogens among the community-acquired ones, gram-positives, and fungal pathogens. For almost 8 or 10 years, we were concentrated mainly in the tertiary care hospitals. Our reports are published annually. Many of you may have referred to them in the past. Recently, we thought we would not be able to gather nationally representative data unless we move to the next tier of hospitals, which is the secondary care hospitals. That's when we launched a new program, and hospitals like Believers Church, they are further helping us work with the secondary level hospitals, because secondary level hospitals do not have very good labs. Some of them may not have a full-time microbiologist, and they would require a little bit of capacity building as well during the process. And that is where the hospital like yours, who have good labs, who have good experience of running these labs, can actually help us not just get data from secondary level hospitals, but also build the capacity of secondary level hospitals. Over here, I would like to mention that one of the secondary level hospitals which Believers Church is working with, they had, when we did the external quality assurance, they had a score of 69 or so in the first cycle, and then the next cycle they improved to 97. So this is the kind of contribution, I think, when we get from the hospital like yours, that is very, very meaningful for us. You are not just helping enrich the data in the ICMR surveillance network, you are also helping the hospitals in your own state to grow and build their capacity. Now we have 54 hospitals in this network. And this is the NCDC network. Both the networks, and there is another network that we have in the country, which is the Healthcare Associated Infection Network, and there are almost 80 hospitals which are part of this network. And the aim here is to build capacity for infection control in the ICUs in these hospitals, is also have a check on hospital-acquired infections. Because hospital-acquired infections are the major chunk of infections that we see in our hospitals, and almost 90% of the infections which are being treated in admitted patients in the ICUs or in the wards are coming from the hospitals. They are hospital-acquired. 80% of Klebsiella pneumoniae and 91% of Acinetobacter baumannii were resistant to imipenem in this particular network, which was published in Lancet. This is from India, and 63% of Staph aureus and 42% of Enterococcus were respectively oxacillin and vancomycin resistant. So this really paints a very grim picture for the patients who acquire these pathogens while they are admitted for other reasons. And this is also data from India again for the neonatal sepsis, again increasing neonatal sepsis to carbapenems and third generation cephalosporins. Now this is the data from our latest annual report, and this is the ones which was released for 2024 data. And what we see is that there is a very high burden of enterobacterials in our, which is by marked by pink here, and then this is followed by gram-negative non-fermenters and staphylococci. We see fungal infections as well. As you can see that teal blue is the fungal infection, 0.95% among the total isolates, but in blood it is almost 7%. I would say this is an underreporting because many labs are also, they don't have capacity to do the antifungal susceptibility testing. Now this is the top 10 species that we see. So it is mostly E. coli, Klebsiella pneumoniae, Pseudomonas, Acinetobacter is around 10 or 11%, then Staph aureus and Enterococcus. Fishium is actually increasing, and so are Strenotrophomonas and Burkholderia. And this is the location-wise distribution. So what you can see is that we see a lot of Acinetobacter baumannii here in ICUs, especially whenever, so Acinetobacter baumannii is an indication that the infection control is compromised, whenever you see a lot of A. baumannii. So, similarly, but in most other wards or OPD, we see mostly E. coli and Klebsiella pneumoniae. What we see is also very different. Government hospitals, since they spend less on infection control, they have a lot of Acinetobacter. But private hospitals, Klebsiella pneumoniae is the predominant pathogen that we see from the ICUs. So just to summarize the trends, we see the ESBL rates are around 70% in E. coli and Klebsiella pneumoniae. Carbapenem resistance is around 10%, maybe increased to 20% last year. Klebsiella pneumoniae 40%. Then increasing resistance to colistin is being reported. Salmonella typhi, 100% sensitive to ampicillin, chloramphenicol, and cotramoxazole, and cefixime, and increasing resistance to ciprofloxacin, almost 80% resistance. For diarrheal pathogens, resistant to quinolones is very common now, and azithromycin is more useful for treating diarrheal pathogens. Among the gram positives, we see 40% MRSA. Linezolid resistance has gone up. It is almost 2% now. And vancomycin resistance is 3 times higher in Faecium as compared to Fecalis. 30% resistance to caspofungin and fluconazole in Candida glabrata and Candida auris. These are all the reports that we publish every year. They are all available on ICMR website. We report data of almost 1 lakh isolates every year. And this data is, I would say, coming only from the tertiary care hospital. So our report is always published with the rider that this is not applicable to the general samples. For example, your hospital will have lower rates compared to what we report. So this is only guidance. So recently, last year, Honorable Prime Minister also cited ICMR report and brought out this message. This, I think, was very powerful, that there was admission at the top level that there is a problem in the country and the communities should use antibiotics responsibly. So coming from the highest level, I think it got a lot of traction. Based on the reports that we have published so far, we divide drug-resistant pathogens in Indian hospitals into 3 groups. Group 1 requiring aggressive action. So over here we have carbapenem-resistant enterobacteriales, carbapenem-resistant Acinetobacter baumannii, drug-resistant Salmonella typhi, and Candida auris. Group 2 requires sustained action, and this includes ESBL enterobacteriales, multi-drug-resistant Pseudomonas aeruginosa, VREs, azole-resistant Candida, and the pathogens which are still we are able to treat very well because they have good susceptibility to commonly used antimicrobials, but still they would require continuous monitoring and prevention efforts, and that is MRSA, azole-resistant Aspergillus fumigatus, amphotericin B-resistant Aspergillus flavus, drug-resistant Strenotrophomonas, colistin-resistant enterobacteriales, and Acinetobacter species. So this is the susceptibility trend for the key antibiotics, which we have seen in last few years. For example, for E. coli, what you can see is mostly what we are seeing is that it is decreasing susceptibility. Only for 2 drugs, amikacin and ceftazidime, we have seen increase in susceptibility. Let us see if we are able to sustain this trend over years. Similarly, over here for Klebsiella pneumoniae again, we are seeing increasing susceptibility to amikacin as well as ciprofloxacin and ceftazidime. For carbapenem, because of excessive use, the susceptibility has been consistently dropping every year. But this, whether this is a 1-year phenomena or we are able to sustain it, only the last year report would know. This is 2024 data. Now we also do genotypic characterization to understand what are the mechanisms of resistance, what plasmids, what chromosomal mutations have happened, because this is the data that our pharma companies need to develop new antimicrobials. So whether it is NDM or OXA, and even the clinicians use this data to decide the treatment in their hospital. So we publish this data as well in our annual report. Now for Pseudomonas aeruginosa, as you can see, the susceptibility to most drugs is around 70%. And 100% to colistin, and main mechanisms are NDM and Win metallobic-lactamases. For Acinetobacter baumannii, it is very low susceptibility. It is almost 20%, which is a very bad news for any patient having Acinetobacter, and mostly OXA23 and NDM. And the only to minocycline, the susceptibility is above 60 or 70%. So now, when we look at what are the mechanisms of resistance which are circulating in our country, we know they are ESBLs, they are OXA48, and they are NDMs. What is important here is that all these drugs, which one of them has already been introduced, and 3 of them will be introduced in near future. They will not be active against the mechanisms of resistance that we see in the pathogens from our country. So this is the bad news, because they are not active against all these mechanisms or the genes which, or enzymes which are produced by the Indian isolate. So that's why we need more data on this to motivate companies in our country so that they start innovating and developing antibiotics. So the new treatment options are urgently needed. That's why the evidence is very important. And what we also need at the same time is the stewardship around new products, because we should be able to rationalize and use them responsibly. Otherwise, these new drugs will also meet the same fate which the piperacillin tazobactam has or other drugs have, where we have almost 70–80% resistance now. So now this we started the antimicrobial stewardship. We started in 2017. We organized all these workshops. But before that, we did a landscape analysis as to what is the capability of Indian hospitals to implement antimicrobial stewardship program. And we realized that most hospitals, especially government hospitals, neither had ID physicians, they neither have clinical pharmacists. So there was almost no investment on antimicrobial stewardship program. There were few private hospitals who were doing it very well. So in collaboration with hospitals like Hinduja, Apollo, and few other hospitals, we initiated the capacity building. And for the hospitals which were part of ICMR, AMR surveillance network, and subsequently we funded them for implementation of antimicrobial stewardship interventions. In the first phase, we just funded them for implementation, for putting together the framework of AMS in their hospitals, and we did that with good amount of success. Post the intervention, which is seen in orange, most hospitals had an AMS document. They had AMS committees. The committees met regularly. They were able to do AMR data analysis. The point prevalence of cultures improved. So 2 hospitals even created permanent positions of clinical pharmacist after the project was over. And but the hospitals, they continued to face the challenge of funding, time available for this particular activity, because AMS is not recognized as a separate activity in most hospitals. Now, whenever we do such initiatives, we make sure that we provide supporting resource materials. So we released the AMS guideline in 2018. Then a new one is under preparation. ICMR has been continuously releasing treatment guidelines. The National Medical Commission has made it mandatory for all medical colleges to have AMS and HIC committees. Now, it is also mandated that every hospital should have a 24/7 functioning microbiology labs. We also released the National Essential Diagnostic List that makes it mandatory for all district hospitals to provide blood culture facility or any urine culture facility for free. And the strengthening of district hospitals is underway. Now, all the rationalization cannot happen at the level of the hospital. The regulations also have to support. So that's why we are continuously in touch with the CDSCO, which is the drug regulator of the country, and for the essential list of medicines so that there is access to antibiotics. Government launched Red Line campaign. There is Schedule H1 to regulate sale of antibiotics. We also work with the CDSCO for banning of inappropriate fixed drug combinations. There are many fixed drug combinations which are approved mostly at the state level. For example, recently we came across a combination of ceftriaxone and vancomycin to be administered together. So these kind of things, whenever they are brought to our notice, we bring it to the notice of DCGI. And twice they have banned a group of antimicrobials. And now all such FDCs will be put up to the central CDSCO. This has been the result of ICMR efforts. 2 new antibiotics have been developed. ICMR also has a MOU with GARDP, which is the Global Antibiotic Research and Development Partnership. GARDP has a objective to develop at least 5 new antimicrobials in next 5 years. And ICMR has the network. We have the hospitals who have the capacity to do these clinical trials. So they will be bringing few products to India in next few years, which we will be doing clinical trials on in next few years. 2 new antibiotics have been developed by Wokhart, which have benefited from the data which we produced at ICMR. One is nefithromycin and the other one is the Zenic. This is still in news. This was a very recent FDA approval which happened about a week ago. And this is the drug which is cefepime-zidibactam. It has a beta-lactam enhancer approach. And this will soon be approved for treatment of carbapenem-resistant infections in India. Now, as these new products hit the market, we are worried about their overuse. That's why we did a consultation with DCGI that all these drugs in the pink, when they are launched in India, we should have a mechanism that they are not overused and abused. So the consensus was that these drugs should not be put out in the retail market. They should be available only in the hospital formulary. And also the hospitals should have some qualifying criteria like having a good IPC in place, having a audit system, AMS audit system in place. So only then those hospitals will be allowed to place these drugs in the retail pharmacy. So it is a very fine balance. The company wants to make money on the drug that they have developed after so much investment. And then we say, don't oversell it or overuse it. So, but at the same time, for the benefit of the patients, we need to maintain that balance. So AMR and One Health are really in vogue these days. Everyone is talking about One Health and what is the contribution of One Health in AMR. There are various efforts which are going on like wastewater surveillance, there is veterinary surveillance. So we did some studies because a lot of antibiotics which are used globally, 70% of them are also used in veterinary sector, fisheries sector, and for many crops. So what we did initially, we did in collaboration with Indian Council of Agriculture Research, we created a network of hospitals where we tried to understand what is their capacity to do antimicrobial susceptibility testing. We worked with the ICAR, we built their capacity, created a integrated surveillance network. But over a period of time, when we look at the antibiotics which are used in the animals and be used in humans, we see that the classes of antibiotics are very, very different. Except for few products like fluoroquinolones, which are overlapping across both. Most of the antibiotics, for example, piperacillin, tazobactam, meropenem, to which we see almost 70% resistance, is not used in animals at all. So when we talk of addressing this challenge in the clinical settings, we should be more aware that the cause and the solution lies with us only, and we can't be, pushing the blame on the veterinary sector. So this study we funded in Delhi, in PGI Chandigarh and CMC Vellore. We wanted to see what is the overlap of veterinary, clinical, and the environmental isolates. And what we found was, maybe this may not be visible to all, but what we found was that in the human, which is blue is the clinical, red is the livestock, and green is the isolates from the sewage environment. There was good amount of overlap between the blue and the green, because one is the clinical isolate and the green is the hospital sewage, which is coming from the surrounding areas. But the ARGs from the veterinary, which is in the red, they had very limited overlap with the clinical setting, thereby indicating that there is very less transmission, limited evidence of spillover of antimicrobial resistance from Klebsiella as well as from E. coli from animal or environmental reservoir to humans. So the point here is to understand that there may be some sporadic events that may be happening, but mostly the transmission is from human to human, and it stays within the hospital. It essentially doesn't go to sewage and goes back to human or from the poultry. So we focus mostly now at ICMR on the human and the clinical aspects of antimicrobial resistance. Nevertheless, we have been constantly working with the FSSAI, with the Indian Council of Agriculture Research, and it was on ICMR's insistence that they introduced a ban on use of colistin as a growth promoter in animals. There is now mandatory withdrawal period for use of antibiotics in food producing animals, specified limits of antibiotics and other pharma active substances in seafood, restricted antibiotic use in aquatic animals, but this is on the insistence of Ministry of Economic Affairs, because a lot of exports get rejected. I'm sure Kerala knows it very well. Monitoring for antibiotic residues in eggs, honey, milk, and poultry for export. Now, these are some of the projects which ICMR is currently funding. Now, the first one is evaluating the impact of influenza and pneumococcal vaccination. Now, one of the things is that one is addressing antimicrobial resistance in the hospital or rationalizing when the patient comes with an infection. What if we are able to prevent these infections in the first place? There are many vaccines which are available which we can put to use. One of them is the typhoid vaccine, for which impact studies have been done. There is a good amount of benefit of administering typhoid vaccines. The other most important is, and people like us who live in Delhi understand it more, because regularly we endure the pollution and everything towards end of the year, and we see soaring respiratory infections all across all age groups, especially in the elderly population. And so we are doing one study in which we will be doing influenza and a pneumococcal vaccine to elderly age group, which is the 60 plus age group, and then looking at mortality, hospitalization, and what is the cost of treatment of and use of antimicrobials in this group. Now, the second project is expanding AMR research and surveillance to secondary hospitals, of which your hospital is a part. Developing in vitro diagnostics for typhoid. Now, we understand that there is a problem in treating typhoid because there is no good diagnostic. Vidal is not good enough. Blood culture rarely is tested positive. And then the other options we have is Typhidot and similar kind of tests. So ICMR is funding 4 groups for development of a molecular-based test for typhoid. And the next one is applying next-generation sequencing technologies to detect drug-resistant priority pathogens and improving clinical outcomes. Now, most of the hospitals are able to, the tertiary care hospitals which ICMR is funding, they have sequencer in place, they are able to undertake NGS. What is the advantage of doing NGS, and what is the direct benefit to the patient when we are able to provide result in, say, 6 to 7 hours as compared to 24, 48, or 72 hours? How does it impact clinical outcomes? So this is one aspect which we are focusing on. And for future action, ICMR continues to generate robust evidence so that it makes a solid case for investment, not just for policymakers, but also attract companies like Wockhardt and many others to invest in development of new diagnostics and new antimicrobials. But at the same time, we need to work on the framework so that whatever research outcomes are there, whatever products are being generated from these research outcomes, there is a framework to take them up. Normally what we see is what is developed in the lab takes forever to reach the patient. So the instruments like National Essential Diagnostic List will serve that purpose. Then regulatory guidelines, which I already spoke about for introduction of new drugs in the market, sustain the ongoing initiatives on infection control, antimicrobial stewardship at all levels of healthcare. This will be our next step going forward to introduce appropriate AMS at secondary level hospitals, and what will be the minimum package which we can implement there. Support basic and clinical research and innovations, how we can use AI and ML to plug the data gaps that we have, especially for AMR surveillance. And one thing which we have not done till date, I would say we have failed here, is engagement of civil society. The kind of campaigns we see for TB, the kind of campaigns we see for HIV/AIDS, we haven't seen something like for that in AMR. And that is, I think, one of the reasons that AMR still is a silent pandemic. So now this is a very important area, reason being that we are already missing out on a lot of sustainable development goals, and if we do not address AMR, it will further impact 9 sustainable development goals across all of them. And this is, I think, my last slide. There are various guidance documents which ICMR has developed. They are available on the ICMR website. So if any one of you want to understand it further, kindly look at them. And thank you, everyone, for turning up. The hall is full. I rarely see full halls for AMR related presentations. But thanks, everyone, for turning up, and I'm happy to answer any more questions.
Thank you, dear ma'am. That was an enlightening session. So we also used to present the antibiogram in the same quest sessions. And as you have rightly pointed out, our Klebsiella CRA is on the high rise when compared to the other hospitals in the state itself, wherein they have a lot of Acinetobacter pneumoniae. And then the other point that we noted was minocycline susceptibility for our Acinetobacter is very poor. And all the other findings were somewhat similar to the ICMR AMR. And we always communicate with the physicians on what are the good susceptibility patterns so that they can use it for the next year. And so now the floor is open for discussion. Any questions, please, you can ask.
I'm a pharmacologist, and I don't know whether you know my name. I'm Sumit, and you were involved in providing a grant for me for my PhD thesis for colistin model building, population model building. So thank you for that, and it resulted in 2 good papers published in well-indexed journal. I have a few questions. Now, we have started TDM, therapeutic drug monitoring, in our institution, I think actively since past 6 months. And we are seeing benefit, a huge benefit for the patients who actually receives the TDM treatment, TDM-based treatment. You have mentioned about piperacillin tazobactam, and there is no animal use, but still resistance is going up. So we are seeing that our patients, even with a dose of 9 gram piperacillin tazobactam Q6H, some patients are not achieving adequate antibiotic exposure. So the same is the case for carbapenem antibiotics like meropenem. And we see that TB, rifampicin, is a highly underdosed drug. Pyrazinamide is on the higher side. Many patients develop liver injury because of that. So we are able to optimize treatment for our patients, but now the problem is it's not well taken into the society. TDM is still, many hospitals nearby also are not aware of this miracle management system. and we would like to offer it to the nearby hospitals. I would like to know whether the ICMR has any future plans for incorporating TDM or at least suggesting TDM when it is required as a part of the antimicrobial stewardship program.
Thank you, Dr. Sumit, and I see that we did well at funding you for and therapeutic drug monitoring actually for bacterial infections hasn't been discussed much. I would be very honest here. It was brought up in some of our antimicrobial stewardship discussions that whether the treatment guidelines should also talk about TDM, but as you know, we are a very heterogeneous country, and the capacities which are available in some hospitals and some hospitals just are not there yet. So that's why we wanted to keep it very generic, that at least the hospitals who are willing to start AMS should be able to make the beginning, rather than thinking of if we have to do TDM, why should we even start even something basic. So because they don't have capacity to do it. But yes, we did discuss TDM very seriously for antifungals, and some of the research was done around it, but we did not really take it forward. It was not translated into action. But yes, I take this message very seriously, and we will discuss it as one of the points in our upcoming antimicrobial stewardship meeting, and we will see what we can do to create this capacity at least in some of the few hospitals, and also understand what other hospitals are doing, because some hospitals I know they are doing, but that is more localized and within the hospitals wherever there are pharmacologists like yourself who are there and who are able to bring it to the notice of the clinicians. But thanks for raising it for our attention, and we will take it forward.
Thank you, ma'am. It was a very intriguing session. I had two questions. One is, you showed this pattern of antimicrobial resistance through the ICMR data. Is there a state-wise difference in what you observe? Question one. And second, particularly in Kerala, that you have a ban in the over-the-counter sale of antibiotics. Do you see a visible change in the spectrum of the resistance? That's one. Second question is, many of us, when we practice empirical antibiotics in neutropenic patients, we follow a certain pattern, most likely derived from our training centers. Wherever we were trained, we follow that wherever we go. And that is kind of uniform across colleagues everywhere. So do you have any comments on that kind of practice, or how to improve it? Yeah.
Now the first one, your first question was comparison of national data with the Kerala or any other state data. I think we did this once, and except for the drugs which are used in community where the susceptibility was slightly different and lower in the states data, we did not see much difference in other antimicrobials. Reason is that even the carbapenem resistance data would be coming from tertiary care hospitals, mostly from where there are admitted patients and others. So, and many of them, the hospitals which actually submit data, they also receive a lot of referred patients who have come with the previous hospitalizations or surgeries, who have also received all kinds of antibiotics during their hospitalizations. So from ICUs, there isn't much change. We will still have a relook at it, because now after implementation of the antibiotic ban, it takes a while. It doesn't come down immediately. So it takes at least a couple of years. I think going forward, we will be focusing more on it. And your next question was on, remind me, sorry.
The training, ma'am.
The training, yes. So as you know, as I mentioned, we are a very heterogeneous country. You know, wherever, for example, PGI is very different from Apollo, is very different from AIIMS, New Delhi, or others. So that's why there is a need to create that standardization across the country, which is not going to come easily. And that was the reason that we released the treatment guideline. There was one which was released in 2017, after that in 2019, and there is a recent one which has been a joint effort between National Center of Disease Control and ICMR, and it is a joint document which has been developed with the participation of hospitals from both private and the government sector. Their consideration was given to representation of doctors from South, North, East, West, everywhere. So when we release this kind of guideline, we expect doctors to follow that guidance. But it doesn't happen sometimes. But at least when the document is out there, there is more opportunity for creating that uniformity and standardization. But at the same time, I think it is the prerogative of the doctor, and the doctor must remain autonomous to treat the patient the way he likes. And that is where your comment on, depending upon what kind of training you received, comes in. But at the same time, I'm also an optimist. I feel that if the environment in which the doctor is working, if that environment promotes certain practices, they do improve over a period of time on an individual. So I think it is not just one factor, that the training remains with us forever, and you people are constantly evolving yourselves through CMEs and many other academic exercises. So there is a lot of opportunity to improve those practices over the lifetime of a doctor. But we need to provide that support and resource materials that encourage that, and also talk about examples and case studies, which I'm sure you people are doing here very well, to document the good practices and with good outcomes, and that makes a difference. But that is the personal, how perceptive a person is on all these things.
Actually, with the ban on the antibiotic, over-the-counter use of antibiotic, actually the antibiotic consumption have decreased a bit. That was the Kerala government. Recently they have actually, I don't exactly remember the percentage, but there was a decrease in antibiotic consumption, overall consumption in the state.
Was anyone worried about the economical aspects of it?
Yeah, I am Dr. Mohan Rees. My question is, we are actually vaccinating large number of patients with pneumococcal and influenza, large elderly and patient with diabetics. And I found that they are less ill and less number of hospitalization. And various publications in the previous COVID infection also, they published that those who are vaccinated with influenza vaccine has got less incidence of COVID infection and complications. And you can, with the help of someone else, you can retrieve the data from our EMR, and large number of data may be collected and can be helpful in that re-hospitalization and mortality reduction in elderly patients. So unnecessary antibiotic and other things can be reduced.
No, Kerala is always one step ahead of the entire country, I think. And yes, I'm in touch with Dr. Rajalakshmi, I think, who's part of that initiative. And when we were deciding what vaccines we should be giving, we did do all the systematic reviews and looked at the data. So we had an option to do a 4-arm study, which is pneumococcal vaccine, 1 arm with flu vaccine, 1 with both, and 1 control. But then 4-arm study is very difficult to do. And right now we have a 2-arm study, the pneumococcal vaccine and flu, and then there is a control group which gets something else, but not these 2 vaccines. But there were ethical questions on this as well, that when we already know there is a benefit of giving vaccines, why are we doing this study and not implementing it? But then for government to implement anything, they need local evidence. Most of the evidence is available from Western countries only. And what we found was that the pneumococcal and the flu vaccine, they have a synergistic effect, and even some of the cardiovascular issues, there is protection from these 2 vaccines. So that's why we are hopeful that we will get good results from this particular trial, and we should be able to push the government to include 2 vaccines for, and by then I think your implementation study will would have been documented benefits from that. So overall, I think in next couple of years we should look forward to having more vaccines added to the government's adult immunization program, which till now had only COVID vaccine.
Any other questions? If no other questions, thank you, ma'am. I would like to invite Dr. John Walia sir and Dr. Sunny Kuruvilla sir. our associate directors to honor Dr. Kamini Walia with the Ponnada. Gentlemen. I would like to invite our dear principal, Dr. Elizabeth Joseph, professor and head of the Department Pathology, to felicitate Dr. Sanjay R. Singh and Dr. Bhavana Yadav. So Dr. Sanjay Singh and Dr. Bhavana Yadav both are consultant scientific in the division of descriptive research, ICMR. Thank you all. Thank you all for coming. Coffee is served outside.